Thank you for joining us for our annual John Lawson lecture. Dr. John Lawson was an excellent clinician who worked in Dundee from 1948 to 1986. He served in the Army Medical Corps and was a founding member and later leader of the college. He was heavily involved in education and he was known for his wit, but mostly for his dedication to patients. He was often known to come off the afternoon play from college work in London to go straight into the evening surgery. I'm surrounded by colleagues this evening like Dr. Lawson, who do the job out of devotion to our people. We just want to provide the best service that we can, and I'm sure that description applies just as much to our guests this evening. Earlier this year, after meeting our college leadership team, it was announced by our First Minister that we had been heard and that he was persuaded. This message was received well as a very welcome acknowledgement of general practice. Since the First Minister's announcement that action would follow to support general practice, there have been welcome investment announcements. Today, general practice delivers the vast majority of patient contacts with only 6.5% of the NHS budget. And funding as a proportion of the NHS has dropped by a third over the last 20 years, yet we have increased activity and efficiency. We are in a stark situation. However, with relatively small but critical investment in general practice, we can meet the challenges ahead with efficient, evidence-based and patient-centred care, providing the backbone to the NHS. Without it, there is no doubt that general practice cannot survive. As a provider of 90% of patient contacts, neither can the NHS. And if lost, it will almost certainly never be rebuilt. RCGP Scotland's new paper describes the value of general practice in the hope that this acts as further evidence of how general practice is the solution to many of the NHS problems and presents a vision of general practice strengthened and secured for a generation. Many of you will know my role in working with how climate and health interacts, and I hope we can find time to discuss how clean air, better diets, insulated and ventilated homes, access to safe paths to travel and green space, and mitigate and adapt to climate change, improve health, reduce inequalities, and boost the resilience of the economy and reduce pressure on the NHS, making it easier for patients to seek relief. Not to mention the urgent need for electronic prescriptions. In simple terms, climate action is health action, and health action is productivity action. Colleagues, please join me in giving a very warm welcome to our speaker this year. We're all looking forward to hearing what you have to say, and I'm particularly looking forward to an evening of frank and honest, yet calm, constructive, and respectful discussion. Scotland's First Minister, the Right Honourable Mr. John Swinney.
Thank you very much, Munro, for the introduction. Thank you to the Royal College of General Practitioners and East of Scotland for this very welcome opportunity to engage in conversation about the issues that are of importance to general practice, and it's my privilege to speak on the occasion which you remember John Lawson and the contribution that he's made to healthcare in this city and further afield. I'd like to begin by picking up on one of the points that Munro mentioned, which is about the kind of wider context in which general practice finds itself within our society. And 80% of a person's health is determined by factors that are outside of traditional health settings: education, employment, income, housing, food security, access to green spaces. I want to start by acknowledging two things. First of all, the centrality of general practice services as essentially the pathway into health services for individuals in every single part of our country, and therefore it is essential that such services are available and accessible to members of the public. But secondly, to recognise that general practice is not in some isolated compartment of its own, distant from other factors that we are wrestling with. And the reason why I say that is that the approach that I am taking to government as First Minister, which has been informed by many years of experience in public life and in serving in different roles within government, is that the government has got to have fundamentally a cohesive programme that will address the needs of the public. And if I've got one lesson from my years in public life, you must work hard to establish the connections between different areas of policy so that you get the benefits of those connections within policy. Hence, that comment that I read out to you there of 80% of a person's health being determined by factors that are outside the scope of healthcare. And I give that background to essentially set the context of what I would like to say to you tonight about, first of all, the importance that I attach to the role of general practice. I cannot see how we deliver credible health services in every community in the country unless we have effective general practice services available in all of our communities. But for those services to be impactful and for them to deliver the outcomes that we need with members of the public, they have to be connected to the wider context of the delivery of services within our community. Because even in the conversation, the really helpful conversation that I've just had over dinner with a number of your colleagues, it's absolutely crystal clear to me that general practice is, yes, delivering direct intervention with members of the public and in providing the healthcare that they require. But there are a whole set of other connections upon which the well-being of those individuals will depend, if not properly addressed, will result in the presentation of even more unmanageable demand to general practice and to health services across the country. So my fundamental view of general practice is that it is an essential part of our community, and I have got to take deadly seriously the warnings and the concerns that have been expressed to me by general practitioners about the attractiveness and the sustainability of the service. So I'm not going to stand here and say to you, you've got no issues to raise with me. I'm here to understand better the challenges that exist and to try to identify within the government's policy agenda how we go about trying to address those issues. And there are some issues, some interventions that we've announced in recent weeks and months, which I think will be of assistance to general practice, but I'm not going to say to you that that will be sufficient to address all of the issues about which you are concerned. I think they are indications of the pathway that I want to take to make sure that we strengthen general practice services within our communities, but also that we recognise the interdependence between general practice services and other aspects of the health service and the other aspects of public services in Scotland today. Because one of the issues which was explained to colleagues earlier on, and I am now spending as First Minister a very significant amount of my time in the working week addressing issues within the health service and interacting with representatives of the health service, interacting with my health secretary, working with the leadership of the health service in Scotland and in discussions with clinicians and others. Because there are challenges that exist across the whole suite of health services in Scotland. You know, the issues that I've prioritised have been the need to tackle long waits for treatment and the need to enable better access to GP services so that people's needs in communities can be met at an earlier stage. So those are my two overriding priorities in relation to the health service. But there's a connection between the two of them. If we can't do something about long waits, then general practitioners are going to be seeing the same patients over and over and over and over again because secondary care can't deal with the issues that need to be addressed. So the approach that we are taking. We spent again today. I have a session after every meeting of the cabinet with leaders of the health service in Scotland and representatives of boards around the country to focus very directly on the work that has to be undertaken to reduce longer waits so that we can get more movement in the health and care settings. We're also addressing issues around delayed discharge, which are an impediment to the effective working of the health service. And along with that, considering what other steps we can take to strengthen general practice capability in Scotland, recognising your connection, your position as a pathway of access into healthcare services in Scotland today. I make that point to demonstrate that there's an interconnectedness of GP services with wider challenges in the health service that we have got to resolve, that we've got to get right, so that we can act to ensure that members of the public get the healthcare services and interventions they require, and that we act to reduce what I would describe as the repeat presentation within general practice, which is not an efficient use of your time, and certainly not beneficial to members of the public who might well be wrestling, and likely to be wrestling with healthcare issues that are becoming more and more acute and more difficult to resolve the longer they wait for service. So the focus of my attention in the health service just now is on those two issues, about reducing long waits and about improving access to general practice services. And although we've taken a number of interventions in that respect, I don't want for a moment to suggest that that is the end of the conversation, because in terms of what I've aired tonight with colleagues, it's been incredibly informative and valuable for me to hear those views, and I commit the government, as I know Neil Gray, the Health Secretary, is doing, to continued ongoing engagement with the Royal College of General Practitioners and with BME Scotland and their GP committee on the issues that need to be addressed within general practice, and that will be an ongoing commitment that we take forward. But all of this fits into, I think, some of the wider questions that we wrestle with in public policy in Scotland today. And I mentioned earlier in my remarks that the government has the programme of the government is focused around four major themes: around eradicating child poverty, around growing the economy, making the transition to net zero, and improving our public services, and particularly our health service. And I make reference to that wider context of the government's programme to make the point that we cannot view healthcare services as somehow in isolation from that. Because if people are languishing on long waiting lists, they're not able to go to their work and be taxpayers and contribute to the economy. If they are not able to physically be able to engage in our economy, their ability to contribute towards the efforts that we need to achieve net zero is diminished. If we have children languishing in poverty on a persistent basis in our society, Scotland is never going to get out of the pit about the challenges that we face as a society. And in all of these objectives, these themes of the government's policy, there is an indivisibility of our actions across different areas of policy that are relevant to ensuring that we achieve all these objectives. Child poverty will not be eradicated just by me increasing a particular benefit payment for families, because there's a housing element to child poverty, there's an early learning and childcare element, there is possibly, and most likely, in a lot of cases, there'll be an addiction aspect to eradicating child poverty, there'll be an employability aspect, there will be a transport or an educational aspect to all of that. So my point there is that there is a critical set of connections that need to be established to make sure that we can meet the needs of individuals, provide whole family support to try to help them to move out of poverty or be able to move out of poverty. And general practice on a key role to perform in all that. In this city, in Lawson, we've been taking forward an exercise with a range of partners, including the City Council, Department for Work and Pension, our own Social Security agency, and benefiting from the information that the Department for Work and Pensions can give us about those individuals languishing in poverty, and particularly with children in poverty. We've been able to engage in dialogue with those families about what to design a route out of poverty for those families. And it's not a single magic stroke, it's a whole collection of different issues and factors that have got to be borne in mind and addressed to make sure that family is able to be supported out of poverty. I've shared with colleagues an example that was shared with me where a young woman with children, the route to starting to get her out of poverty was the City Council fencing off her garden and improving the outdoor space so that her children could get out of the house safely and play, and the tension in the house could reduce. Now, the Chief Executive of the City Council said to me, not in a month of Sundays would we have had sort out the garden as a top priority in the journey to eradicate child poverty, but it was the route to starting it and to delivering a better outcome for that lady and her family. So the need to see an indivisibility of connection between the different areas of policy and different interventions is central to what we've got to achieve. And I was asking colleagues over dinner about the extent to which general practice feels connected to those wider set of solutions, or whether it feels remote from them or even excluded from them. Because undoubtedly, the general practice will be able to make more impact on people's lives in addressing a range of healthcare issues that are presenting to general practitioners. If there is a wider context that is supportive to the achievement of good health outcomes for that individual, whether that's about good housing or education or tackling addiction or whatever it happens to be. So that whole connection is vital for us. And I suppose it's one area that I will explore further as a consequence of my conversations tonight, is the degree to which we can strengthen the way in which general practice is connected to other areas of policy, not viewed as a sort of standalone feature over here in its own distinctive space. All that is relevant, I consider, to the whole question of the sustainability of our public services. And of course, I hear loud and clear the message from general practitioners about financial support for general practice, about the importance of strengthening budget provision to enable the recruitment of more general practitioners and to strengthen and to expand general practice within Scotland. I hear that loud and clear. You will also be aware of the multitude of other financial pressures and demands that exist on the public finances at this particular moment. So all of that raises questions about the financial sustainability of our services. But of one thing I'm absolutely certain, we've got to find a route to fiscal sustainability for our public services so that members of the public can still access general practice services and other healthcare services in the way that they have been able to do so and can rely upon for their support. That vision of a national health service that is available free at the point of need is absolutely essential to the outlook and the ethos of my government. But we've got to find a fiscal sustainability route to enable that to be delivered. And we're giving a lot of thought to this, and as you'll probably be aware, in the course of the next few weeks, the government will set out some important contributions in this debate around the population health framework, which I'm very grateful to the Royal College of General Practitioners for contributing to, and also the service renewal framework, which is another element of how we design the approach to service planning and to workforce planning that enables us to meet the expectations of the public and to deliver sustainable services. But before we get on to any of that, we have got to be prepared to embrace a more fundamental principle, which is that in all of our public services, this is not a health service related point, this is a wider public service related point, we have got to accept that if we want to ensure our public services are fiscally sustainable, we have got to have greater emphasis on early intervention and prevention in all of our public services. So before the government gets on to setting out population health framework and service renewal framework, I'm going to set out the perspective of the government, which is not a short term, it's not a kind of here today, gone tomorrow strategy. It's going to be an underpinning of government policy of a presumption in favour of early intervention and prevention, because that is the means by which we can ensure our public services are sustainable in the period that lies ahead. And in that respect, the way in which we have all got to collaborate and cooperate to find new ways in which we can deliver services that are driven by that prevention principle, that early intervention principle, requires us to think about how we deliver services and about how we engage with the public in so doing. Some of that is about, in the space of healthcare, in leading the debate with the public about the importance of public health and about how people take the steps that they can and should take to ensure that they are living a healthy lifestyle. And there's huge obligations on government to lead that debate and to lead that approach. And one of the proudest moments in my parliamentary life was voting for the ban of smoking in public places in 2006. As an opposition member, I took enormous delight in doing that. And you can see the fruits of it in our society today. The introduction by my government of minimum unit pricing for alcohol was another of those steps. Now, if I think back to both of those particular interventions, banning smoking in public places was described by one senior cabinet minister of the United Kingdom government as the last pleasure of the working man being able to do this. Basically, all the people that had to endure the passive smoking that went on with it all. And minimum unit pricing was going to be the end of the world for the drinks industry, neither of which has come to pass. So there's a bit of courage that's required in embarking on that message about healthier lifestyles. And when I had a health incident a few years ago, and I got some care from clinicians in Edinburgh Royal Infirmary, a consultant very delicately asked me at the end of the whole process, how heavy were you when you became a member of Parliament? And the answer was shockingly embarrassing. And I took up running as a consequence. And I've tried to look after myself to a great deal more than I was doing up till then. And leading that debate and encouraging that debate with members of the public is crucial in how we get to a more sustainable position. So there are approaches that we will all have to take, and we will need your engagement and your involvement in helping us to lead those debates and to lead those discussions with members of the public to enable that to be the case. But in amongst all of this, in this respect, I come back then to the challenges within general practice. We have to be engaged in a dialogue about how best we can work together to address the capacity and scale questions that exist within general practice. That has to involve ensuring that we are able to recruit sufficient general practitioners to sustain services around the country. That means general practice has got to be attractive as a career proposition. We have to, together, work to create the idea and the concept that general practice is the key pathway into healthcare services that needs to be available to all in all communities in an accessible fashion. But to do that, there has to be capacity and scale and access to do that. Not all of that will need to be face-to-face encounters with general practice. That's what some of our most recent interventions have been about. We're trying to divert some of that activity into pharmacy first services, for example, which can make a contribution but will not be able to resolve all of the demand that will be placed on general practice. So I want to make sure that we are able to work with you to expand general practice and to ensure that our primary care services remain resilient and responsive and best able to meet deliver the best possible outcomes for patients. We've also got to make sure we've got the mechanisms to enable people to join the profession. The Career Start Fellowship, which is delivered here in NHS Tayside, is a programme which, from all of my examination, delivers an excellent grounding in general practice, and we need to make sure that similar ventures are available in other parts of the country to ensure that we are able to deploy that model in a wider set of areas around the country to support with the expansion of general practice. And there'll be other particular suggestions that will come forward. The focus in the government's programme on the cardiovascular disease enhanced agreement is designed to ensure that we are adapting and innovating about the way in which general practice is able to deliver its service provision to meet the best needs of the public in Scotland. So on all these questions, I hope there's you have the sense that the government is willing to be engaged in that conversation and to find ways of reaching solutions that will sustain general practice and make a positive impact on the lives of individuals in our country. Above all else, I want to express to you my appreciation for what you do, and that I don't in any way underestimate the scale of the challenges that you face, nor do I underestimate the scale of the difference you make in people's lives and the outcomes that are achieved as a consequence of your intervention and those with whom you work at local level. And what we've got to do within government is work constructively and collaboratively to make sure there's a secure future for general practice in Scotland. And it's my privilege to give you that commitment here tonight, and one that will be echoed by the work of my Health Secretary and by others on my behalf. But please view this as another moment in the conversation, not the end of the conversation, another moment in the conversation, and I look forward to taking that further with you. Thank you very much.
Very much, Mr. Swinney. I'm going to use Chair's privilege to make a couple of comments, and then we'll move into questions. And hopefully you can help me with any themes of questions from online as well, to make sure we represent that a moment in conversation and an ongoing conversation, and that is exactly what we want. Great to hear your comments on the determinants of health, and we do acknowledge the financial pressures. And I guess one of our key messages from our document that's the value of general practice is about the return for investment, and we know it's roughly 14-to-1 return for investment in general practice. And you mentioned the smoking ban in public places. That's an example of public health measures which also give £10 to £14 of return for investment. Good to hear your comments on pathway into healthcare. I would add that most people that come to us, we treat and we deal with, where it's not just a pathway to other parts of the healthcare system. Most of what we see, we deal with, which is part of the efficiency of general practice. Really appreciate your comments on how essential general practice is, and I think the tone of your desire to listen. And I think if you and your colleagues are wanting solutions and suggestions, I think you're going to get some great comments from our audience this evening. So I'll open to the floor and online for any questions, please. I've got some ready just in case.
Thanks very much. John, thank you very much. It's really great that you could come along and devote some time to speaking with this engagement thing that we find out very, very important. So, first of all, big thank you for that. I'd just like to start off taking up some of your points about our engagement with the wider services, because I think that is very important. It's part of what General Practice has always done. One of the ways we've tried to do that recently in the most recent contract and some of the iterations of that was GP clusters, where groups of GPs will engage with health and social care partnerships, and part of the extrinsic function of that is to engage. But it seems to me that the health and social care partnerships, their budget is increasingly under strain, often because of the drug costs that they have to meet, and so we don't seem to be getting the value that we may do from GP clusters. We don't necessarily seem to be able to get the support that we might need from partnerships to deliver more of what we could do. So we're spending a bit of money but not delivering full value. How do you feel we can improve that and look at that, to get that engagement, or do you feel there's a different way that we should be engaged?
I think it's a welcome route, but I think the thing that I think I am most concerned about all aspects of the public services, and this is not just about general practice or about healthcare, is about compartmentalisation. And often organisations deal within their own sphere and they don't see the connections to other places. And that therefore also affects budget control and the degree to which they're open to ways of working that will perhaps share budgets, have collaboration around budgets, make the money go further as a consequence of joint endeavour. And listening to your point here makes me feel that might be part of what's underpinning this, because I'm obviously aware of the challenges within health and social care partnerships financially. But trying to create a sense of good collaborative working where we are focusing on the effectiveness of spend as opposed to controlling compartments of spend is, I think, the route through. So in terms of the model, the approach, I think it's absolutely bang on. Will it be generating all the value that you could be generating from it? It doesn't sound like it is. And that's where I think the emphasis on that environment of collaboration is crucial in that respect.
Thank you. I've got a question here.
Can I ask, is the Scottish Government 100% behind the partnership model? And if so, what do you think over the last 5 years they've done to show that? And going forward over the next 5 years, what will you do to show that?
Partnership model
For general practice.
I think the government is committed to, the government is committed to partnership model. Just keep getting indulgent. So that's the way it tends to operate. And I think the government is engaging. There's a contract renewed or renegotiated in 2018, which has been taken forward. I've set out some recent changes to allocation of spend, which are designed to help general practice, and I don't think that's the end of the conversation. We've got to expand capacity to ensure that we meet public needs. So the government is committed to that model, and in amongst all the themes that I've talked through tonight, we've got to find a way of making sure that has the greatest impact possible for you, for making sure that the profession or that this role is attractive to new entrants, because we need new entrants. Acutely aware of the challenges that exist in some areas and localities about general practice services, and that what you do is crucial in reducing the pressure that will inevitably grow in other aspects of healthcare if your intervention is not accessible and early. So I talked a lot about fiscal sustainability, but there's a whole question of just the volume sustainability of the health service with an ageing population. So the earlier you can be involved, the earlier impact you can make, the greater the impact that will be.
Can I just come back to that a little bit? With regards to what you're saying about the connectivity of the different areas of public service and the ability to work in grey areas, we are your solution to that. We are a massive part of the solution to that. You know, the room will be full of experts and working outside of silos, with lots of different areas of the public health service. So I would say we are your solution to that, and amongst all our colleagues. I think we're a major part of that solution.
But does it feel like that?
Well, it certainly feels like we're very connected with lots of people, and it feels like that we shoulder a lot of the burden of that for a diminishing part of the budget, which I understand the pressures of them. I would say we are the solution to that. For a massive part of the solution, we can work much better for you, given the right emotions.
Thank you. Any further questions from the floor before we get some online ones, please?
Thank you. Really great speech. I'm interested that smoking indoors was one of the proudest moments of your career. How about e-cigarettes, vaping, advertising to children, potentially banning? What are your thoughts? Because that's the next public health intervention I'd have thought waiting to happen.
And you know, we've just taken measures to ban single-use vapes, and I am profoundly uneasy about the vaping culture and the damage that could potentially be done to people's health and well-being. So we have got to look further at the ongoing public health threats that we face in vaping as well.
So how do we help you with that? How do we make your job easier?
We need evidence, an evidence base to help us to come to these judgments. You see, the thing about smoking in public places, the evidence was incontrovertible. You had to be totally facing down the evidence that opposed that policy move. Some people were prepared to do so, and it was a total fan of the approach. So so evidence is crucial to win that argument.
I'd like to get some questions from online. I'm sure there's plenty.
Yeah,
I come over to the
I'm going to unmute this, see if that helps.
laptop.
Do you have to speak now?
Yeah. Okay. So we're seeing more membership, increasing numbers entering foundation training. There's been no comparable expansion in core and higher specialty training posts, which creates a bottleneck and undermines workforce sustainability. When will Scotland have a comprehensive and publicly accountable workforce plan that maps our current and future health needs to funded and deliverable training and staffing establishment that actually meets them?
Okay, and I realise the importance of these steps. The service renewal framework will help us in that endeavour, but the approach to workforce planning is it's a constant focus within the health service to ensure that we have appropriate levels of resources available to us. But I think some of the challenges that we face now are affected by some of the volume of candidates emerging from training, and we essentially have to marry up those the demands of the service with the numbers of the medical training facilities to enable that to achieve.
I think that links with, I think what it feels like in the NHS is that there is a certain level of demand and there's a certain supply of resources, and we are bridging that gap in the health service. I think it's probably similar with the need for planning. I think it's beyond the witted man to work out what it costs to provide a certain health service, but at the moment it feels like there is a gap that we are bridging. And that makes two questions on here from Masmac and Ken Lawson. over 30 years in general practice, many times we've heard the importance of GPs and the need to move funds from hospital to community. The reality but general practice in Scotland is in crisis and dying because of a lack of funding, 6.5% down from 11% of NHS budget. Currently, England and Wales, 8.6%. A first step would be to increase funding available to practices to develop the services required close to their patients. A commitment was made in 2016 to increase funding to 11% by 2021. The question
and that was that's to me a variety of things. Here, so we've given a commitment to increase the proportion of the importance of early intervention are critical in essentially reshaping that balance, because without that, there will be huge questions of the sustainability of healthcare services in years to come. So, I suppose the assurance I gave you is that there's a practical imperative that we do that to ensure the sustainability of national service across the board, and that shift into primary care, general practice, and the early intervention is critical for that route to sustainability.
So do you think that means not just new funding, but over 5 to 10 years, getting that proportion back to target of 15%?
I think the target, you'll forgive me if I don't make the company's budget for next year. But I think.
Any further questions from the room?
I do a lot of stuff. Truly health centres. You visited my colleagues recently to the contrast of what we've managed to achieve. And with a bit of investment, you can deliver a really different health. I want to deliver some of those outcomes you're looking at because it gives them the capacity and space to have that wider team.
More to than financial stuff, and you know to read this up. And because I think there is
the Dundee Medical Schools in first instance. Thank you to you and the Scottish Government. Wondered about your comments about the fact that particularly we draw on students who come from areas of widening access, and NES who fund the travel and placement arrangements for students, particularly about wanting to place them in more rural or remote placements, are considering a cap on reimbursement of fees for travel and or accommodation, which means that we might be forced to think about not sending students to further remote and rural to inspire them to be the next generation of GPs. So NES have their own challenges, I'm sure, with finances, but if they do that, it's really going to impact on the next generation of potential GPs because they're not joining up the pieces at the moment. And I just wondered what your thoughts would be about that.
first of all, from the University of Dundee, obviously I appreciate your comments, and I'm very much involved in. The government is very much involved in making sure there is future for the University of Dundee. There's such strength there. We can make sure that we navigate through these difficult moments. And on the NES funding point, let me take that away. I feel that could be the point. It's if we're trying to attract a wide range, a range of applicants from a wide range of backgrounds and some unlikely backgrounds, then we've got to make sure there are no impediments, no impediments to their engagement. So don't take that away. That's what I can do. Thank you.
Thank you. Thank you for coming along tonight and for the opportunity for these conversations. I was thinking about what you said around interconnectedness between access and waiting times. And I'm really interested in that because I can see how there is quite an obvious link between if you have long waiting times, it impacts on the demand on general practice. But I would like to switch that on its head and think about what we mean when we talk about improving access to general practice. So some of that obviously is about having enough appointments available, having long enough appointments. Some of that is about having quality of appointments so that you're able to talk about the things that matter to people. But a lot of it, I think, increasingly we're recognising is access to relationships, access to someone who knows you well, who knows your story, who knows your context, who's able to tailor your care. And so I think that if we had improved access in all the ways that we talk about access, not just activity, but also relational access, then we start to see impacts on waiting times in a different way because we have better conversations earlier on in people's journey and we understand more what matters to them, whether or not they would wish to be referred at all. I'm sure there are probably quite a lot of people on waiting lists who maybe don't need to be on waiting lists. If they knew about alternatives to treatment, if they had different types of conversations, it's quite difficult to know what the scale of that is. So I think, again, general practice can be part of the solution around waiting times. And it's not just, it's at all points in the referral journey. It's at the point where someone first comes in with symptoms, having the time to have a proper conversation and understand what's really going on, having access to specialist support to know whether or not referral is needed, and then thinking about the people that are on the waits. So I think in terms of how do you get to a point where we're able to offer more relational access and more continuity of care, there are lots of different component parts to that. We have a part to play as a profession in thinking about how we train and enable our workforces. There's lots of different elements, but I think politically the things that would make the biggest difference to make it feel like that's something that we could see in our future as GPs and as citizens is something about the public dialogue around speed of access versus seeing someone who knows you well. So when we talk about access, it's a much wider conversation about seeing the right person for you, and also simultaneously growing the capacity of the workforce so that we are able to meaningfully meet people where they are and have those conversations. So I think, I'm sorry, that's a long sort of reflection and question, but I'm just unpicking a little bit what we mean by interconnectedness between those two things, because I think there's quite a lot of two-way traffic.
I think there's, thanks, Mark. I think there's two distinct points that I'm making. The first is about where we find ourselves just now, whereby where people are waiting for a long time. And tell me if I've got this wrong, but this is what I keep on getting told. People who are waiting a long time for secondary care keep on coming back to the GP and use up appointments because they're not getting that secondary care. So, and I suppose that's me acknowledging that part of an increased workload of GPs is, and please don't, if I do say this incorrectly, that kind of, obviously unproductive appointments. They're just repeat appointments because the person's not getting the underlying issue. And that's a symptom of where we are just now, hence why I'm trying to get long waits reduced. I wouldn't want that to be mistaken for in any way downtown the importance of relationships in care and medicine. Because I think it's, I think listening to GPs, I think that's possibly the element that probably grieves GPs, that they know, that that's the foundation of all the strength of the service. But it's difficult for you to deliver it because it's just, you're under so much pressure of time and volume and cases. And that's where we've got to either expand the number of GPs, expand the capacity so that more relationships can be built, or we've got to reduce the demand by making sure that people are getting to those outcomes as a consequence of relationships the first time round, or more than likely a bit both. So I think the importance of when I think about as Shane's colleagues are on in my wife's own care, my wife is MS, we faced a moment of crisis about 15 months ago. So much so, and I'm not disclosing secrets, so sometimes at the weekend we decided to hear our soul about this. If the vacancy for leadership of the SNP, the First Minister had risen a month before it happened, I could not have done it because I had such a fragile situation at home because of a deterioration in my wife's condition. But one phone call to the clinician who has supported her for 22 years without interruption meant the intervention was swift. And as a consequence, the pathway to recovery and strengthening was so much faster. Now, if that had been a struggle to get access to that intervention, I'm not sure how we would have managed. So fragile was the situation. So kind of dilemmas. I totally see the value, that's what I'm trying to say, of relational medicine and clinicians understand where you are. So it's not a surprise. It's crucial. And I recognise just how challenging it is for general practice to get into that space.
Thanks for your answer there, First Minister. We're all wishing the best for your wife.
She's done.
There's a couple of comments here I'll share. Thanking you for your thoughtful presentation and the acknowledgement that general practice is not the same as primary care. The key issue being the shortage of general practitioners. There's another comment about if GP capacity is reduced by 1%, that could mean around 20% more patients turning up at the comment on there.
Can I just sort of on that? One of the things I should say in my comments is that I might be saying this, but let me say it again just so that I can satisfy myself with it. I'm acutely aware of the whole system nature of the challenges that we face. So, you know, when I think about the kind of issues that I was wrestling with over the Christmas and New Year period of intense pressure on NHS 24, ambulance stacking in various hospitals, which is not an uncommon issue, that congestion of access to A&E, hospitals operating at some cases over the Christmas New Year period, 102, 103% of capacity, the rate discharges sitting around about 2,200, and that's a dangerous topic. So, recognising the importance of having a solution that works for the whole system is what I'm trying to say to you. So therefore, general practice being available and accessible has the potential to reduce that presentation demand at E&E, which presentation at E&E is fundamentally more expensive than presentation at GP practices. So let me make that well true.
Time is against us. I think we had one more question at the back here, and then we're going to hand over to our chair for a comment on our paper, and then we'll be on to awards. I think someone had their hand up the back. Yeah.
Thanks, Chair, and thank you, First Minister, for coming to speak to us tonight. This is a slightly shorter point than Harry's. But just to say that on productivity and on sustainability, which we're all acutely aware of, could we please have electronic prescribing? It saves money, it saves our time, which gives us more time with our patients, and it will save the planet so that our patients stay safe. Thank you very much.
So, about electronic prescribing.
The funding hasn't been allocated.
Yes.
So
£12 million would be enough to get electronic prescribing up and running in Scotland, the way it is in our big neighbour. And it's one thing our English colleagues cannot believe at conference that we don't have. I am still writing cheques in an era when everybody else taps their card to put it into other checks. And that takes a lot of time. And the bits of paper go missing, and the patients don't like it, and the pharmacists hate us, and and everything in between. And so it makes the point that there's a lot of system time that could be saved, and what we're looking for, I won't say quick wins, because we've been looking at this since I started in practice 20 odd years ago. So but to get it over the line would be really, really helpful, and it would free up time that I think we could all do with using practice.
I think I'll stop asking questions. This gathering, I'll ask a few questions when I get to St Andrew's more.
sounds good. All right, I'm going to hand over to Chris Provan, our chair.
Thank you, First Minister. Thank you for your speech. Thank you for answering questions honestly, and we really appreciate your answers.
appreciate your time away from your family and campaigning in the by-election, all these things to come here tonight. Really, thank you for that. You're in a room of GPs, which means we work really, really long hours. But you probably work longer hours than you do. So thank you. So, as I say, I'm Chris Probin. I'm a GP job and chair of our College of General Practitioners. And since I became chair of our college, I've had one clear aim, and that is to promote a career in general practice. It's a very, very fulfilling career. I've been doing it for 30 years, and it's most of the time it's been very, very good. And being a GP is a privilege. It's a very rewarding vocation working with patients. It can be challenging, but the rewards are there. And we form the bridge between medicine and our patients' real lives, and connect them into the service and work with them. General practice is here for our patients 24/7, 365 days of the year. But we have reducing numbers, as you know. So there's less of us to spread around. And we can sometimes feel undervalued, even invisible, and not connected into the system. So it's good if we become more connected and get the sense that we're being listened to more. Across my 30 years of my career, I've seen the increase in the complexity, the intensity, the volume of the workload. And that's really meaning that it's becoming difficult to sustain emotionally, safely for our patients. So my message is general practice delivers enormous value for our patients, connected into our communities with the help of community link workers, value really to the NHS and our role in prevention as well, as you mentioned, and really our value to Scotland as a whole. I think Munro stole my £1 spent in general practice gives you £14 back in the economy. Talking about the economy, and you say investing hopefully gives us a return. So we published a paper setting out how general practice can hopefully be part of the solution. Whole person medical care, the value of the general practitioner. And we've been glad to share it with you, and would ask you to really have a good look at it and take it on board as part of our ongoing dialogue, as you said. So these guys, GPs in Scotland, act as a shield and protect the rest of the NHS, holding that clinical risk and that complexity in the community so it doesn't leak out into the rest of the system and clog it up. And this is beyond the reach of any straightforward protocol, using the depth and the breadth of our training and our experience. And we also teach, train, and inspire the next generation of the workforce. And GPs really are team players and team leaders, and really show everybody what the significance of working in primary care is. So we need to resist this drift towards industrialised and transactional medicine. And if we're going to achieve together that caring, patient-centred, realistic medicine, there's no substitute for an unhurried consultation with your general practitioner. And the evidence shows that. This is not just some nostalgic idea. This is looking at the evidence of what actually works going forward. So tonight, we have been integral to the vision that we share, really, with you, First Minister, of a healthier and more equitable Scotland going forward. and general practice, as I say, can be a solution to the NHS crisis there. But we'd really like to thank you once again for your speech and contribution. I'm going to hand over to Thank you very much. So traditionally we give a grade for the speaker at the lecture. So look forward to putting a little bit of whiskey in that.
Thank you very much. Thank you. Thank you. Thank you.
I'm going to hand over to David Schack for the next part of the award.
Thank you very much. I've greatly enjoyed this evening. It's been absolutely fascinating. It's good to hear what's going on in the wider health service, and it's good to have respectful debate and discussion. It's what we need. It's part of what we need to do as GPs to engage with the wider system. And politics is the wider system. It is important to us. It's important to listen and to share and to debate so that we can take things forward. It has been excellent. Thank you. The other thing we're here to do, of course, is to celebrate some of our own successes as well. You know, this evening is about celebrating the legacy of Dr. John Lawson, but there's other people to celebrate as well. I'm indebted to my predecessor as Provost, Dr. Gordon McClay, who put the heavy lifting in developing some of the awards we've got tonight. The first of those is entitled to the Provost Medal. And this is really to go to an individual who has given a lifetime of dedication both to general practice and to the college. And the nomination for this award, the nominator said, this doctor was passionate about patient and family-centred general practice. His enthusiasm for the RCGP assessment was inspiring. My own career wouldn't have been where it is today without his encouragement, a true example of resilience and dedication. And I can add to that as well. When I came to Tayside as a new young GP and then became a GP trainer, the mentorship, the kindliness, and the involvement that was given to me by this recipient was second to none. And what Dr. Alex Watson has offered to the college in developing assessment, membership of assessment by performance has been absolutely wonderful. A college examiner and a heritage guys at Euston Square as well. Wonderful. But I think I have a feeling that what Alex will be most proud of is the care of his patients at Westgate Health Centre. That relationship care that we've been talking about over many years that really gives a fulfilling and wonderful career. Alex, the First Provost Award. Thank you very much.
Very proud to receive this award, particularly members, friends and colleagues. I'm particularly pleased because it's John Lawson who isn't accurate really. I was taught by John Lawson as a fourth-year medical student at Dundee Royal Infirmary. He was one of two GPs who did any teaching at all in Dundee. The other one was Morris Dorworth, and he was an inspiring man. I became his trainee in 1977. It was a long time ago, and it was an inspiring year, hard work. And then a few years later, I became his partner, and we called him the big man. He was big in stature, he was big in ideas, and big in influence, certainly on myself. There's a lovely portrait of him, which hangs in the college in Euston Square, painted by Dundonian Alberto Morocco. And I pass that on my conducted tours, and nod towards him, and he looks down with his specs just there, still keeping an eye on you. So it's a great honour to receive the award, and thank you very much.
Very much, Alex. Unfortunately, the recipient of the next award, which is the Faculty Education Award, can't be with us tonight. He's recently retired and he's away in his camper van. I'm sure a lot of you will know and have worked with Dr. Barney Riley, a GP in Perth, the Red Practice of Whitefriars, a great general practitioner, but really being honoured today for his contribution to GP education as an undergraduate tutor, as a GP trainer, and later on as a training program director and a trainer of trainers. He really touched just the lives of undergraduates, of postgraduate trainees, but also trainers. His humour, I think, will be remembered by everyone, his humility as well, and his enjoyment of the job of GP educator. And I'll mention that Barney is given the award. Those are two awards we have that are important, honouring people who have given their commitment over their lifetime in general practice. The next award might actually be the most important because it's celebrating somebody starting off their career in general practice. This is the Faculty Prize for Excellence in the Fourth Year GP Attached. We've got to hope that actually we can inspire and encourage young doctors to take on this great role. So I'm delighted to give this award to Miles Keith.
Very much. That draws to a close to the evening. I think the message is we have been heard. I'm very proud of my colleagues here. I think you'll see that we have a lot of expertise in the room and online. We have the solutions. So dialogue is open and I'm looking forward to working together. Thank you very much.